Yep.
All right, here we go. Can you hear the video?
You'll now be able to get help on how to select certain drugs to treat conditions like stroke and diabetes, as well as know how much you'll have to pay for them.
Now, this comes as the Health Ministry published its first set of guidelines on its website. They include information on subsidies for some drugs. Vimita Mohandas reports.
Medical technology has enabled people to live longer and better lives, but it has also resulted in rising healthcare costs. And so the Health Ministry set up the Agency for Care Effectiveness, or ACE, to identify treatments with the best clinical outcomes at the most affordable prices.
Previously, we used to be, in a way, passive price takers. So, if a company came to us and said this was the price of a drug, then we would basically say yes or no in terms of, subsidy decisions. But here we are saying that at a particular price, then this drug becomes value for money. And there is then that opportunity for us to talk to industry about what is a fair price for the drug.
One of the drugs assessed by ACE is for stroke prevention. Novel oral anticoagulants, or NOACs, and warfarin are used. ACE assessed that NOACs are just as effective as warfarin and safer, with a lower risk of bleeding in the brain. Warfarin is also highly effective, but there's an increased risk of internal bleeding, and the patient has to be monitored regularly. Diet is also restricted. But NOACs cost 30 to 50 times that of warfarin. As such, ACE then recommended that rivaroxaban, a type of NOAC, be applicable for a subsidy under the Medication Assistance Fund. This published table shows that the initial sale price for rivaroxaban ranged from $4.40 to $5.70 per day. But after negotiations between ACE and drug companies, a patient can now expect to pay up to $3.08 per day for the drug, without subsidies, and those who qualify for maximum subsidy pay 77 cents. Previously, hospitals bought drugs from various suppliers at varying costs. As such, one doctor welcomes this standardization.
If ACE is able to negotiate drug prices for us, then it keeps things very standardized. I mean, if you go to a restaurant and you order chicken rice and you know it costs $5 or something like that, there is no negotiation. I think the idea is that, if we're able to be transparent about drug pricing and this is at a more affordable rate than previously, it's already considered a positive step.
The other drugs include those to treat cancer and diabetes.
Now, by the way, it turns out this is an old video. There's lots of drugs and some devices that ACE has actually looked at. Now, the reality is, and I know I have a few folks in here from the ministry and a couple of folks from the private sector. I think the experience from ACE, and certainly it depends who you ask, but you get a sense of this from the video. ACE, I was here before ACE, and I think the value that ACE brings is that it's systematic. And I'll talk a little bit more about ACE as we go through, but certainly there's a systematic approach for evaluations that has certainly changed throughout the last decade or so since it's been created, but it allows you to understand sort of the process. Now, I think the other thing that came up in the video, and those of you involved know this, is that ACE, yes, they think about cost effectiveness and they think about value for money quite a bit, as well as other things, but they really also use this as a negotiating tool, as a way to get prices down. And I think that's what industry is most upset about, but certainly from the taxpayer perspective, you can see the value in it. So, ACE and NICE and HITAP and others, my argument would be all very similar, all have a systematic approach for trying to evaluate drugs and devices. Some nuances, some differences, which we can talk about. And in fact, for example, NICE in the UK and HITAP, the subsidy decision and the approval decision are essentially one and the same because they're universal coverage countries. In Singapore, products tend to be on the market for a couple of years before they're even considered for subsidy. So I think ACE has a different role than the Health Science Authority, which is the equivalent of the US FDA, the approval body. So certainly there are some differences, but I think that, using health economic techniques, health economic evaluation methods to evaluate products is unique, not unique to Singapore. It's common in all countries. And I think negotiating prices is increasingly common in all those countries. And of course, whether or not a drug or device is cost effective is going to depend on a bunch of things, but the biggest one is going to be how much is the company charging. So it becomes a significant negotiating tool. So I know I have a couple folks from industry and government in the room. Does anybody want to talk a little bit about your experience or add to this discussion? Anybody had any involvement with ACE or in trying to get a subsidy or deny a subsidy, maybe? Well, maybe not in this call, but if you welcome any input if anybody has experience. Okay, so let me talk a little bit about my approach. And I published a paper a couple years ago with a couple of former colleagues that is the way that I've seen this play out over and over again in the public and the private sector in terms of appraising the value of health technologies. And you can think about this from the perspective of the government, who may be the one to provide a subsidy, or the perspective of industry who's trying to convince somebody to provide either reimbursement or coverage or payment. And basically, these 5 steps don't have to be in any particular order. But what I tend to do as a consultant and what I've seen over and over is there's lots of studies around quantifying the burden of a condition, economic or otherwise. And of course, if you want to convince somebody that there's value, you have to show that the intervention is effective and safe. So those, we'll talk a little bit often with cost, randomized trials, but not always. And then we'll talk a lot, starting in a month or so around cost effectiveness and other types of economic evaluations. But cost effectiveness is the big one for government. For private sector, it's really profit maximization. It's understanding what is the return on investment. And market or budget impact analysis is part of that, as we talked about, because to really understand the consequences, you need to know something about take-up rates and how that varies as a function of price. That's going to be part of your budget impact. And then I'll talk a little bit about some of the other arguments that people will use to try to convince somebody to provide reimbursement. So let me just give you a couple examples. I'll go for about another 10 minutes or so, and then we'll take a break. So if you look down at my sort of burden of illness research, the first step is, if you're trying to convince somebody to provide coverage or reimbursement, is you have to show that burden is high. And burden can take lots of different forms. And so if you look at the data, there's prevalence and trends, there's forecasts, there's morbidity, there's mortality. And then a lot of my work has been around quantifying direct and indirect costs, economic costs, productivity losses, what have you. And in our Monday course, you'll learn about how to do this using the medical expenditure panel data and other data sets. And I'll teach you in this course as well a couple of different ways that you can use data to quantify direct or indirect costs. And one of the things I've found is that in the types of economic burden studies, industry and government tend to be aligned. And so both want a good understanding of what drives costs. And so oftentimes, certainly with ACE and industry and others, it's like, okay, pharma or device, they want the government to provide a subsidy, and the government wants to ratchet down on prices. So there's sort of this antagonistic relationship. But the reality is both want to understand where are the significant barriers, or I'm sorry, the significant costs of conditions. Where does the burden come from? And so I've certainly worked on projects that are joint partnerships with industry and government to better understand the burden of various illnesses. And I'll show you in a second a multi-$100 million, if not billion-dollar effort to quantify the burden of diseases around the world that is largely funded by government, industry, and private sector sources. And then we publish a lot of these papers because part of the reason that you want to show burden is to convince people that, there's a problem, so that you can then come in later and say, I have a solution. Now, I'll talk a little bit about global burden of disease country profiles. This is the company that I was talking about. Well, company is not the right word. It's called the Institute of Health Metrics, or IHME. Used to be out of Harvard, now out of the University of Washington, and they've gotten over $100 million in grant funding from the Gates Foundation and lots of other funding to produce burden of disease country profiles. And they use what's called disability adjusted life years, or DALYs, as a way to measure burden. And I'll talk a little bit about what DALYs mean in a couple of slides. But just to give you an example, so if you look at Singapore, you can see here what causes the most deaths. Actually, somehow, Chenwei, I had these things animated. I don't know, somehow we lost our animation. But basically, the most deaths, you can take a look here: heart disease, lower respiratory infection, stroke, blah, 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 blah. Lots of these are cardiovascular NCDs, right? So non-communicable diseases. In fact, are they all? I'm trying to think. Ischemic lower stroke, blah, 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 blah. But when you talk about disability, anybody want to take a guess, if you haven't looked at the next slides? What do you think causes the most disability? Any ideas? Well, okay, so you're all barking up the wrong tree: stroke and cancer. It turns out when you look at disability, or death and disability combined, you actually see, for example, lower back pain comes up number 2. You still have heart disease, but if you look just at the disability component, it's things like migraine, it's lower back pain, it's things that hit people fairly early in life and don't kill them, right? So for example, diabetes, where you can get in your 30s and you can generally live for 30, 40 years. You know, if you look at where cancers are on this list, lung cancer is number 7, but the reality is cancers drop off, even though you see liver cancer, colorectal, because they tend to kill people fairly quickly. Whereas the ones that drive disability are the ones that tend to give people illness, make them have a low health-related quality of life, but don't necessarily kill them, like low back pain or even hearing loss, right? Now, by the way, I really like this particular slide. This is, again, from the Global Burden of Disease, because what it does is it lets you see how your country is doing relative to your peers. And so if it's blue, that's good. If it's red, that's bad. So for example, if you look at Singapore, relative to our peers, we're not so good on low back pain and ischemic heart disease, but we tend to do pretty good on these down here on the end, false, for example. Okay, now risk factors. So if you look at risk factors, in Singapore, you see tobacco, high fasting plasma glucose, high BMI, high blood pressure, blah, blah, blah. These, again, you know, okay, fasting plasma glucose, that's sort of diabetes, high BMI, obesity, high blood pressure, you know, too much sodium intake, dietary risk. So really, these are very modifiable risk factors, most of them related to diet and exercise. So that you have air pollution somewhere, you must have smoking. I don't see it here. Huh, I don't see smoking.
Tobacco.
Oh, tobacco, number 1. Yeah, tobacco, right. Now, okay, if you look here, just by comparison, here's Singapore, Malaysia, and Thailand. Surprisingly, perhaps, you know, you see tobacco kind of float around a little bit, high blood pressure, but it's not that different. You know, a lot of these things, air pollution is in there, but, you know, high BMI even comes up in number 2 in Thailand, and it's creaking up in, where is it, in Malaysia, number 3. So dietary risk factors, inactivity, significant, even in countries that historically were, you know, places where we had a lot of infectious disease. Now, here's a question. Somebody want to tell me, how do they know? How do they figure this out? Any idea? Survey, okay. Chun Hong, what do they ask them?
Perhaps they'll ask the self-reporting conditions of that particular person.
You can say, all right, you've got some bunch of conditions, but how do they know that those conditions drive death and disability? So I'll give you a hint. When you look at this, certainly when you look at this is actually pretty easy. How do they do this?
They looked at cause of death data.
Well, they look at the death certificate. The death registry will tell you, okay, for each person, what was their cause of death. So this is actually very easy. This one is actually kind of not so easy, but essentially you're on the right track. You can ask people sort of to report their disability status based on some, EQ5D or some existing instrument that measures disability. And you can ask them to self-report their health risks, and you can try to correlate the two, right? But this one is tricky, right? So how do you know, for example, which of these factors is driving death or driving disability? Time and motions. It turns out it's not so easy, right? There are ways to do it using econometrics, which we'll talk about, and then there's ways to do it using something called population attributable fractions. Has anybody heard that term before? Population attributable fraction? Okay, well, if not, that's good because you'll learn something. And econometrically is another approach, and you'll learn that too in the Monday nights class, for how you can actually use data to generate estimates around risk factors causing death and disability. Census, no, I don't think census picks up anything to do with risk factors. Claims data, again, most hospital data or claims data does not capture information on risk factors. It just captures diagnosis and procedure codes and costs. So we'll discuss these methods. Okay, I tell you what, before I get into this sort of some examples, let's just take a 10-minute break, and then we'll come back in 10 minutes and then we'll keep going. Okay, any comments or questions before I get going? All right, thanks, Chinwei, for straightening me out. I got the right version now. Okay, so let me talk a little bit about some of the work that we've done. So just to give you a background and sort of, what I'm trying to do now is just convince you that the skills you learn in these classes are going to really help you in the real world. And so, when I was doing obesity work in 2000, which was about when I graduated from my PhD, believe it or not, people knew that obesity was bad for your health, but the economic story behind obesity was unconvincing. People didn't believe it. And in fact, the paper that really put me on the map, which has been cited now thousands of times, was this paper that looked at national medical expenditures attributable to overweight and obesity. And we showed in this paper, which, by the way, uses one of the early waves of the medical expenditure panel survey, which is the paper that the data set that you guys will be using in the other course. We showed that obesity was responsible for about 9% of all health expenditures in the US. And I think that was a big number. So basically, like more than, almost $1 in $10 went to treating conditions that obesity promotes. And I think more importantly was that the government in the US paid for about half of those costs through Medicare and Medicaid. And so this was one of the first papers to say, hey, the government is spending a huge sum of money due to the fact that people are overweight or obese. And so maybe we ought to think about doing something about it. And this was actually funded by the US Centers for Disease Control. This guy, Guijin, was a co-author of ours. And worked for the CDC. And actually, this guy, Ian, was my RA. Great guy. And his girlfriend, now wife, was our babysitter. Very nice. Okay. Then we came back and we said, well, actually, a lot of the action is around the cost of obesity to the states through Medicaid. And so, the same trio, Ian and Guijing and I, through CDC, published another paper looking at the cost of obesity to Medicaid. And again, we used medical expenditure panel survey, publicly available MEPS data, which has data on annual medical expenditures as well as demographics and, importantly, people's BMI. Then we said, well, a lot of the action is actually in work sites, and certainly they're the ones who are going to fund interventions. And we suspected that a lot of the costs would be absenteeism and presenteeism costs. And so we actually used an alternative data set, and we explored, well, what are the increases in absenteeism and presenteeism that comes with excess weight? And what we found was that about 30% of the total costs were from absenteeism. And actually, in a subsequent paper, we showed that an even larger percentage was from presenteeism. And all of these papers, this is again funded by CDC, got a fair amount of attention. Now, I'll tell you an interesting story. So back then, this was around 2007, there was a couple of, Barkat, are you tired? This was, there was a couple of weight loss drugs on the market, but they generally were pretty bad. They didn't generate a lot of weight loss, but they generated side effects like oily stools and flatulence. So you can imagine they were not big sellers. Well, it turned out that Sanofi had and actually, by the way, there was a really good product on the market before that, that was called Fen-Phen, or phentermine and fenfluramine combination, which was great, but it caused a few people to have heart valve defects and death. So that one was voluntarily withdrawn from the market. So there really wasn't very much good on the market, but Sanofi had a drug that was called Acomplia or Rimonabant, had two names depending on which country you were in. And it targeted what's called the cannabinoid receptor, which, for those of you who don't know, is the receptor that cannabis targets. And the idea was that it took away cravings. And the drug actually seemed to do really well in clinical trials, and Sanofi was hoping to become a blockbuster billion-dollar drug. And they were funding all sorts of research to do step 1 type studies to show that obesity is bad, bad, bad. And in fact, they gave us money to work with the CDC to produce an obesity cost calculator. And in fact, I did this when I was working at RTI, and we commercialized it, and we put it on the CDC's website. We sold it to employers and insurers and Ethicon, and really this was my first commercial venture, and it made money. So it was kind of a neat experience. And you know, my point here is that the CDC and Sanofi were in partnership here because both were trying to spread the word that obesity is bad. And so our calculator, which was really, you know, kind of an app, although it was based on, it was in a visual basic add-on to Excel, it looked like an app, but it really had Excel underneath. It was pretty neat. Did well. And actually it was two anecdotes to the story. The first is that it ended up being removed from the CDC's website because we got complaints that it produced bias against obese people. And so due to the sort of early DEI type stuff in the US, it ended up getting removed. But maybe more ironically, Sanofi's drug caused suicidal ideation and ended up never getting approved. And so all the people that I worked with were all fired and went on to other things, and the drug went away. But the point is, these step 1 studies, long before even the approval process was considered, they were funding these types of studies to try to set the stage for what they thought was going to be a huge market. Now, by the way, I've done lots of studies on the annual burden and the lifetime burden of various conditions. Here's one on the lifetime medical cost burden of overweight and obesity. Now, type into the chat, which estimates would you say are more relevant? Annual burden estimates or lifetime estimates if you're thinking about an economic value proposition? All right, so, okay. So I like when people sort of have different answers. It makes me think we're learning some stuff. So it turns out Shenglin is right. Lifetime estimates, because the idea is if you're going to intervene and you're going to take somebody, or let's say, for example, our childhood obesity example, if you can prevent a kid from becoming an obese kid and becoming obese in adulthood, you have a lifetime of possible benefits, right? So what is the lifetime cost of an obese individual? That is the maximum potential savings you can get from intervention. And that maximum would be if your intervention is costless and 100% effective. So, I mentioned earlier, I had a call with a reporter last night, and she was asking me if weight loss interventions would be cost saving. And I was saying, well, this is actually a simple question. We have published estimates on the lifetime costs of obesity. We know what the drug costs are. And if the assumption is you're going to be on drugs lifelong, I can just do the present value of the drug, and I can figure out if the present value of drug is more than the present value cost of obesity over the lifetime, then there's no chance it's going to be cost saving, right? And so knowing the lifetime costs is really important for a cost effectiveness analysis. It turns out annual costs are not helpful if the benefits of that intervention accrue beyond the year. So if a weight loss intervention or any intervention has long-term costs or benefits, then from a cost effectiveness or cost benefit analysis, I need to think about those benefits from the lifetime that they're going to have impact. So economic evaluations always take a long-term perspective, at least as long as cost and benefits are expected to accrue. Now, annual estimates are great for getting a publication and getting in the media and showing people that things are expensive, but not for economic evaluation. So let me stop there. Does that make sense? Comments or questions? Okay. So we do the burden estimates because they're publishable and they get in the news. That's really the main reason. So, okay, here was another lifetime one. So let me ask the question. I hinted at this earlier. Is it possible that obesity is cost saving to governments? That the fact that we have obesity means governments spend less? Yes or no? Is that possible? Type your answer into the chat. C1, yes. June says yes. So Kai Hyung, why do you say yes?
Because from the healthcare system perspective, if we can manage the obesity problems properly, the comorbidity can be reduced, and then we can have some cost savings.
Well, I'm not talking about interventions. I'm talking about obesity itself. Is obesity cost saving?
Oh, then no. Yeah.
Okay, Regina says no. So Xi Zheng says similar to smoking, obese people would cost less, or I would say could cost less if they die faster. Right. So here's the issue. Smokers tend to be cost saving because they basically smoke, pay a lot of money in taxes, get lung cancer, and die pretty quick. So smokers tend to subsidize non-smokers when you consider the taxes they pay and the early deaths. Now, for people with obesity, it's certainly possible, but it's unlikely. And in fact, we show that it's not true. And the reason it's not true is because people with obesity tend to get conditions like diabetes and heart disease that don't kill them, or kill them maybe just a little bit earlier. So if you look at the life years lost, the survival difference between obese and non-obese people, it's about 4 years for people who have a BMI of about 35 to 40. When your BMI gets about 45, it becomes like 12 years, but then you're talking about, 50 kilograms overweight. But if you're just mildly obese, your life expectancy is just a couple years, but you can have decades of higher expenditure. So it turns out, whereas the lifetime cost of smoking, depending on your perspective, can be negative, the lifetime costs of obesity are positive, but actually smaller than you might think, because depending on the age that you're thinking about, let's say you're thinking about a 25-year-old, if you discount future costs, and I'll talk about that in a second, the present value of those costs from the perspective of a young person are lower because the real costs of obesity don't come until somebody's older, right? So it's possible, but it turns out not to be the case. Okay. But as I said earlier, lifetime perspective is the right perspective for economic evaluations, or at least as long as costs and benefits differ between alternatives. Here's another worksite paper that we published. Oh, by the way, this paper, I like this paper. So talking about burden, this was a paper that I published in 2012, looking at obesity forecasts through 2030. And, forecasts tend to be, take them with a grain of salt, because if they're right, it's probably luck. And if they're wrong, you can say, well, things changed, right? So we published this paper, and basically what we said, and this was using, this was back in 2011, we said, well, we don't think rates of obesity are going to go much higher than they are now, but we think that the rates of extreme obesity will rise rapidly. So you're going to have many, many more people with BMIs above 40, 45, and even higher. And amazingly, we nailed this one. And so if you look at the data in the US compared to our forecast, we did really well. So I think this is neat. And this paper has been cited thousands of times. Huge impact. Because basically, what does it say? It says, well, if you don't do something soon, you're screwed, right? So these types of papers can have a large impact. And again, these are all really just step one studies, right? So yeah, cited 1,900 times. And by the way, 20 plus years later, I'm still at it. So the World Bank came to me not too long ago, and they said, hey, Saudi Arabia is actually one of the fattest countries in the world. They just put in a huge sugar sweetened beverage tax. They have a vision, 2030 vision, to reduce obesity. Can you help sort of show the economic burden? And so we did. We published one paper looking at the burden. And again, the World Bank is partnering with the Saudis to try to address public health in the country. And so they were interested in this. And then, by the way, I talked about sort of Sanofi, but it turns out Sanofi is not the only one with drugs. And in fact, there are now 2 on the market that are highly effective and have a pretty good side effect and safety profile. One from Novo Nordisk called, what's the Novo drug called? Well, one from Novo Nordisk, whose name escapes me, and then one from Eli Lilly. So 2 highly effective drugs. And so both of these companies are running around the world spending lots and lots of money on step 1 type studies. Ozempic, that's the Novo one. And so one of those 2 companies paid us to do a Singapore-based economic burden study. And so we did it, just, published it in 2022. And in fact, we're still doing these types of studies. So lots of, there's a market. And of course, I'm just showing you obesity, but if you look, every time there's a drug covering something or a device or a public health program, there will be people doing burden studies to set the stage. So big market for these. And I'll talk a little bit next week about how we do them, but you'll learn a lot about it in the Monday night class, right? So blah, blah, blah. Okay, here's the idea. In step 1 studies, you want to say obesity is bad, or whatever your health condition is. It's bad, and it's bad in lots of different ways. And, if it's credible, people will believe it. Now, I've seen studies that I think are not only not credible, but I think they're probably just mean, that, obesity is bad because it's bad for the environment, or, you have to sit next to somebody on an airplane and that's bad. I think you want to be reasonable and you want to be, respectful, but I think the point is these studies work, and that's why governments and industry invest so much money in them. And so, here we're going to teach you in this course about sort of how to do these things and where to pitch them. Now, by the way, just to reiterate, these types of studies are good in drawing attention to a problem, convincing decision makers to act, education, funding, but they don't tell you what to do at all. And in fact, well, actually, let me hold off. I have a question for you, but I'll hold off for a couple of slides. So by the way, have any of you here been involved in actually executing one of these burden of illness studies? Anyone? Well, if no, that's okay. You will in the other class for sure. We're going to get you using the MEPS data to do one. Now, in terms of the skills required, so you'll see next week. I mean, we're going to talk a lot in this course about the econometrics required to do these studies, and you'll learn a lot. Now, I'm going to give you sort of a very introductory approach to doing these using epidemiologic methods, this population attributable fraction. And I think that's good enough for getting you exposure, but the econometrics tends to be how I conduct these studies. Now, by the way, you know, one of the big challenges, and certainly the truth is in Singapore, is in order to do these studies well, you need to know how to do them, how to execute them, but you need data. And so if you have good data, like the MEPS data, there's lots of different types of studies you can undertake, but it requires having rich data at the individual level. If you don't, you're not sunk. There are things that you can do, but it's harder. And we'll talk about that a bit more next week. So by the way, let's see, maybe type into the chat. Does anybody have a burning economic burden of illness studies that you think would be fun to do? Anything come to mind? What is the burden of end of life? Well, certainly looking at end of life cost is something that you could do, but I think that, you know, then the question is to what end? I mean, we've published several studies on end of life costs, but I think to me, it raises the question of the so what question. We know that at the end of life, people are sick, and we know people spend a lot of money when they are sick. So I think the question with end of life costs is, why is that interesting? Regina, is there something specific you're interested to look at?
Hello, hi, can you hear me?
Yeah.
Yeah, so personally, I'm involved in a end-of-life care pilot program. So we're looking at how to actually reduce ED utilization for palliative care patients and seeing how we can actually move their care into home, into a home care setting instead, and how that can actually translate into cost savings as well as quality of life for this group of patients. Yeah.
Yeah, so by the way, I mean, one of the things that I often say, and I said this at the beginning of the lecture, like to me, the goal of providing care is not to save money. And in fact, I don't think that's why we want people to be thinner. I don't think that's why we want people to have better quality of life. And I think it won't happen in most cases. But I do think end of life, because of the high costs involved, there are interventions that you can do. In fact, I think it's one of the few areas, and I run a center for palliative care, so I think a lot about this, where you can probably improve the end of life experience for people and save money. So I do think that's a rare case where that opportunity does exist. And so I think that's great. Certainly be interested to hear more about your work there. Burden of caregiving for frail dementia. So also of interest, and in fact, Chetna Malhotra on our team has certainly published some work on the burden of caregiving. Brain tumors, sure. I don't know how prevalent these things are, but certainly if you have data, you can do it. Sepsis. So by the way, so early detection would be your intervention, but I agree with you. Once you get the burden, you know, if you have a lifetime burden, for example, you can use that in early detection study. So by the way, so some of these things are neat. And in fact, low birth rate is a conversation. Jamie, do you have a particular interest in low birth rate? You're muted. I don't hear you.
Can you hear me?
Yeah, now we can.
Okay. Yeah. So I work in the field of like infertility. So we see a lot of challenges, whether it's in terms of access to the treatment, and also nowadays it's mostly people not wanting children voluntarily. So really just to understand the motivation behind, and of course finally the impact to the economy and what the future is going to be like with low birth rate. Yeah, it's something that I'm interested in.
So what, you know, I've had discussions with some of the neonate doctors in Singapore more around preemies. So these are the babies who are born, you know, 22 to 26 weeks or something, where they're really low birth rate, but they survive. And maybe later, but the question is, well, what is the economic burden of these patients? And in fact, you can actually do that really well, not just looking at medical expenditures, but the data can link to their, how are they doing in schools? How do they do on their, their PSLE tests? How do they, if you have long enough data, what happens to them in the workforce? So there are some really neat economic burden studies. If you can get the trust access to the data in Singapore, you can get, the medical and non-medical burden of all of these babies. Gusto cohort study probably would also allow you to do that. So I think there's some neat burden studies that you can do. Now, just keep in mind that the burden studies, depending on how you do them, may or may not tie back to the benefits of interventions. Brain tumors, I think same thing. So, yeah, I mean, I think these are neat ideas, and certainly, we're happy to provide some consulting ideas if you need help how to execute some of these things. Poverty. Well, poverty is a burden, but it also is a benefit. I think we pay people very low wages, so those of us who are on the other end can have a really good quality of life. So I think poverty is an equity issue, but one we would certainly talk a lot about in my health economics class. But fair point. Okay, so let me switch gears. Any comments or questions before I move on? Okay, so let me talk a little bit about step 2. So step 2 is really the effectiveness step. So, we have to show that there's some unmet need and that we have something to offer. So the intervention improves health outcomes using, some metric that we think is relevant. And, I won't talk too much about it in this course, but basically, industry tends to rely on the randomized controlled trial because that's what governments want to see. But in our other course, in the Monday night course, we're going to show you that actually, if you're clever, you can get at efficacy using other methods, using econometric methods that are actually quite robust. And we'll give you some examples of that in the other course. Now, by the way, my experience is, don't talk about cost effectiveness until you can tell a convincing story about effectiveness. Otherwise, people won't be impressed. Now, okay, so I want to give you guys time to get in your groups again, or different groups, I guess. And what I want you to do is think about a task that I was asked to think about related to the gastric band. Now, the gastric band was one of the interventions to generate weight loss. Basically, it was almost always a laparoscopic surgery where they poked a couple holes in your belly. They cinched essentially a belt around your tummy, tightened it up so you just couldn't eat as much, and you lost a bunch of weight. And the gastric band was approved for people with a body mass index above 35. So people who were obese, but not super obese. And the company who made the band came to me and they said, hey, we have FDA approval in the US for this band to be used for people with a BMI over 35, but we want to convince the FDA to extend the band to people with a BMI between 30 and 35. And so my question to you guys is, what studies would you undertake to convince the US FDA? Now, I will give you a hint. The FDA is like the Health Science Authority here. It's an approval body. It's not like ACE. So FDA thinks only about, I shouldn't say only, but they think about safety and efficacy. They don't think about cost or price. So what types of studies would you want to undertake to convince the FDA, or say ACE, not ACE, HSA, to lower the BMI cutoff from 35 and above to 30 and above? So let's take 10 minutes and hear what you come up with. Can you put these guys in their groups and give them 10 minutes, please, Chinwei? Okay, I think everybody should be back. So I'm looking at the feedback. So again, I like the Padlet, and please take a look at what everybody else has done. But, I'm looking at a few things: systematic review and meta-analysis. But remember, it's not approved. So, I guess you could get data from other countries, but certainly in the US, there wasn't anything available. I think some of you said looking at systematic review of the data from those with a BMI over 40, but that wouldn't necessarily be relevant. I did like the comment here, looking at the somewhere, where was it? Looking at the risks, somewhere looking at the risks of people with the BMI between 30 and 35. So, oh, safety concerns here. So, I don't know who in this group or somebody from your group, can you tell us, would you think that it would be more or less safe to do the procedure for those with a BMI in the 30 to 35 range than the higher BMI range? Jeanette, what did your group say there? What would you think? Jeanette, are you muted? Are you with us?
Sorry, could you repeat the question?
Yeah, so simply put, do you think that the procedure would be riskier or less risky for those with a lower BMI?
I would think it would be less risky, but it's just that the benefits might not justify the risk as much as those with BMI over 35.
So I think that's a fair point, and I think maybe some of you raised this point. I mean, one of the things that I wondered when the company came to me is, well, you know, what do we think is likely to happen for people in this BMI group over time? You know, if we think that they're likely to maintain their weight or even lose weight, then it might not be such a great idea to give them a risky procedure, right? But if we think that they're gonna fatten up anyway, then maybe it would make sense to give them the procedure when their risks are lower rather than wait until the procedure risks are even higher. And so these were some of the considerations that we thought about. And I'll show you some of the things that we came up with. Hold on, I'm switching my screen back.